All right, so meeting you in the virtual sense right now, this is honestly my worst nightmare. I hate looking at myself while I lecture or listening back to myself. But anyways, we're doing what we got to do. So just going to start off how we normally do with our announcements and our agenda. So today we're just going to continue with the skeletal system, go into a little bit more of the joints of the skeletal system. By this point, all of you will have completed your lab practicals. I have already graded Tuesday's section, and I'll be working on grading Wednesday's section. And once everyone has taken the lab practical, including the makeups, we'll go over them in lab next week. That is my goal. I'll pass them back, and you will be able to look over them, ask questions, and I'll be putting those grades in after you look at them. So if you don't see a grade input, don't freak out. I want to give everyone a chance to look over their grade, check my math because I am horrible at math, as you guys have seen. So I like to give you guys that opportunity. Things that are due this week, nothing for lab is due because you have taken a lab practical. There's no new content for you to do for lab. However, you will need to answer lecture video questions, which I'm hoping to embed within this lecture using edpuzzle.com. If that doesn't work, I will supplement just a Word document with questions for you to fill out and you will submit. This will take the place of worksheet number 4. You will not be doing the bone labeling. Instead, it will say lecture video assignment, and that's what you'll submit instead. You'll also need to submit a week 5 post-lecture response, and you're going to use the exam 2 study guide. Exam 1's already done. So don't use that one. Use exam 2 labeled skeletal system and answer 2 of those questions just like how you have been. If you have any questions or difficulties, hopefully you're doing this before everything's due on Sunday by 9:59 p.m. Go ahead and reach out to me. I'll be checking my emails as regularly as I can while I am traveling. All right, so we're going to go ahead and move on. So picking up where we left off, we're going to start off with bone marrow. This is going to be found in long bones specifically. So bone marrow is going to be a soft net-like mass of connective tissue, which is going to be in the medullary cavities of those long bones. That medullary cavity is going to be within the diaphysis or that long cylindrical part of the bone. There are 2 types of bone marrow. There is red marrow, which is going to result in the formation of red blood cells, white blood cells, and blood platelets. So this is going to be very important. That is also why sometimes people will get blood marrow transplants. Their body is not producing enough red blood cells or white blood cells. This is typical in a lot of bone cancers. So when they do a bone marrow transplant, they actually have to go into that central part of your bone and remove it. It's an actual surgical procedure. It's not just like taking blood from your veins when you donate blood. The second type is going to be yellow bone marrow. This specifically is going to store fat. This is inactive in blood cell formation. So yellow marrow does not make any type of blood cell, red or white. It acts just as fat storage. As an infant, red marrow is in most cavities of your bones. As an adult, that red marrow is found mostly in the spongy bone of your skull, your ribs, your sternum, your clavicles, your vertebrae, and your pelvis. So as you get older, red marrow is only found in more select regions of your body. However, if blood supply is deficient, if you're low in red blood cells, your yellow marrow may change back into red marrow to produce those blood cells. So that is a possibility, but that is not yellow marrow's main role. So this is just showing where you can find that red marrow. So that red marrow, as you see at the top, it's going to be found a lot in that proximal end of the bones in that epiphysis region, and that marrow cavity is more central. And we have that yellow bone marrow more in the center of that bone. So a bone marrow transplant, this is what that looks like. So they stick a needle into your actual bone deep enough to get that red marrow. Remember, that red marrow is usually at the proximal or distal ends of the bone on the epiphysis, and they're going to go in as deep as they can to get to that red marrow. I won't play the video just because it might make the recording weird, but on the PDF, you should be able to, it should be a live link that you can click and watch if you want. Unfortunately, I won't make you watch it. If we were in class, I would, but this is the gist. The diagram you see on the right-hand side of your screen. What they do is they collect the cells from the donor, like you see on the left-hand side. They stick that needle into the bone. They typically go from your iliac crest, which is the top of your hip bone or your coxal bone, and they're going to remove that blood. They then put that blood through a machine that's going to remove specifically stem cells, and then the rest of that blood is returned back to the donor. They are only looking for stem cells from that bone marrow from the donor. They then send those stem cells from the bone marrow to the patient who is in need. Typically, the patient will receive high-dose chemotherapy to try to kill any remaining cancer cells before they inject this new blood into that patient. How they inject this blood into the patient is they will do an infusion. So typically, they put it through a catheter, which is going to be a direct IV line, usually into the heart, because that's where a lot of circulation gets pushed out into the rest of our bodies. And then from there, that person is able to create new red and white blood cells. So blood cell formation, how does it come to be? At the beginning of life, that yolk sac of the human embryo is where it's going to start. That is called hematopoiesis, with formation of red blood cells. That's the fancy name that we use, hematopoiesis. Anytime you see hema, it's going to be related to blood. Like if you've ever heard hematoma, that is another condition related to blood pooling up in a certain region of your body. Later in life, that hematopoiesis or that blood cell formation is going to take place in your liver and your spleen, as well as your bone marrow. So when you are just an embryo, it's going to take place in the yolk sac. And then once you're a full-blown human, it's going to take place the liver, spleen, and the bone marrow. So this is just showing as an embryo, we have that what will become your aorta, which is the top part of your heart, is where the blood is made. And then when you're a fetus, it moves more towards the liver. And then as an adult, it will be your long bones. That red bone marrow is where that red blood cell will be formed. So embryo, that yolk sac, when you're a fetus, it'd be made in your liver because those organs will have developed by then. And then as an adult, it will be found strictly in your bones. So not only do our bones hold marrow, red and yellow marrow, it's also going to be comprised of inorganic salts, and it's going to store those salts in the bones as well. That intracellular matrix of the bones, so that internal makeup of the bone tissue is going to contain collagen. We've talked about this a lot already. Remember, collagen is the most abundant fiber you're going to find in your body. So it's also found in your bones. What collagen does for our bones is it provides strength with a little bit of that elasticity. yes, your bones are a little bit elastic, not super elastic like freaking Elastigirl in The Incredibles. You're not like that. Or cats. I swear cats are just made of like a gelatinous substance. Because how can a big cat go through like a gate this big? Anyways, you have collagen in your bones that helps keep the strength of your bones, but give your bones a little bit of give. Those inorganic mineral salts specifically are what makes your bone hard. So that's where we get that sturdiness of our bone. And as we talked about on Tuesday, calcium is going to be the biggest salt or biggest component that's going to be important to your bones, specifically calcium phosphate. Our body requires it for a ton of things. Some of these things also include blood clot formation. You need calcium to help stop bleeding in your body. When you don't have that, there's a condition called, I believe, hemophilia, which means your body just doesn't produce clots, whether internally or externally on the surface. And so, like if you fall and you get a bruise, most of us would just get a bruise and we're fine. But for people with hemophilia, they get a bruise and they end up internally bleeding, which is very dangerous. Calcium also helps with nerve impulse conduction. Without calcium, we're not getting our nerves to conduct that electrical signal, which is going to help with our things like muscle contraction, which we need for not only our skeletal muscles, we also need it for our cardiac muscle. Yeah, I want to keep our heart contracting. That'd be great. And like I said, muscle contraction. Calcium is used for that muscle contraction. So more on that inorganic salt storage. In addition to storing calcium and phosphorus, our bone tissue is also going to contain small amounts of magnesium, sodium, potassium, and carbonate ions. So calcium is not the only player in making up our bones. Those other, how many is that, 4? Those other 4 components are also going to make up our bone matrix. You can accumulate harmful metallic elements such as lead, rhenium, and strontium in your bones just from things you eat or exposures in the external environment. An example of that is going to be lead poisoning. That's a pretty big one. It was pretty big. I guess growing up in the 90s, you know, they stopped making like toys with lead-based paint. And that's because lead poisoning is a very real thing. And some of the effects of lead poisoning will be like it affects your brain. It can be linked to lower IQ, hearing loss, ADHD, damaged nerves. Short-term exposure to lead poisoning can cause loss of body movement, hyper-irritability, and you can die. This sounds like a horrible commercial for like some type of supplement like they want you to take, and it's like you'll be able to breathe again, but you might have like extreme diarrhea or like something unwanted. I don't know. But lead poisoning also messes up your hormones. It can impair cell growth. And as we've talked about, we need our cells to constantly divide and go through mitosis for our body to regenerate itself in different aspects of our body processes. In the stomach, it can cause severe pain and a lot of cramping. With our reproductive system, it can result in lower sperm count, as well as damage to those reproductive organs in general. Our bones, it can slow bone growth, so it can stunt growth. With our kidneys, you could have kidney failure, you can have bloody urine, fever, drowsiness, confusion, literally like everything goes haywire. And then with our blood, it can lead to that rapid heartbeat, shortness of breath, as well as high blood pressure. So lead is no joke. And it still is happening today, just lower amounts since there's been certain laws passed requiring lead-based everything to not be used. This is an interesting story. So when I was researching what radium does to the body, I was like, Google, and it showed me something called the Radium Girls. I'm almost positive none of you have heard of this, so I'm going to take you on a little history lesson. In the 1920s, there were women hired to paint radium on dials of watches. They found that this radium paint glowed. It'd glow in the dark. So they would put that glow in the dark radium paint on these watch dials so that you could see the numbers in the dark. This was mainly used for military usage. We were in the middle of World War One, so everyone over in Europe fighting all hours of the day and night needed to be able to see times and whatnot. So a lot of this glow in the dark stuff was used for military purposes. But how these women painted these dials were they had to take the paintbrush and they had to make it a very fine tip at the end. So to do that, they had to put the tip of the paintbrush in their mouth and like lightly suck on it to get the tip to a point, and then put it in the paint, put it down, put it in their mouth. So they were constantly ingesting this radium. What happened was this radium slowly over time began to eat away at their bones. Their jaws were full on falling off, their spines were collapsing, and their legs were breaking by just standing up. Hips were snapping just by existing. This was a legit thing, it was an actual problem. Radium has a half-life of like 16,000 years or something like that. So these women's bones that have been buried, their bones are still glowing. That's how radioactive they became from licking this radium paint off of the thing. At this time, everyone thought radium was great, was like God's gift to the world, because they found that radium helped shrink cancer tumors. So they're like, oh, this must be like healthy for you. People were drinking radium water. No, not good. Not good to ingest like that. So don't be licking radium paint, just so you know. So moving on to our joints. So joints, the study of joints is called arthrology. That might look familiar, or that first part of the word might look familiar. It might look like arthritis. Arthritis is a disease that affects the joints of your body. Joints, how joints are determined, or just the definition, are when two bones come together to perform a function. So there's varying types of joints with varying bones, and any bone can be bound together at the joints by different tissues. Your body has over 230 joints in it. We have the common ones that we think about, but anytime there are two bones linking up and touching each other, that is a joint. Classifications of joints. So there are some different ways we can classify joints. They're classified by the type of tissue that binds the bones together at that junction. Those three general groups are going to be fibrous, cartilaginous, and synovial joints. So we can also classify these according to the degree of movement. So classifying based off what components they're structurally made of, and classifying them at the different degrees in which they move. How well do they move? Those three types of varying movement are going to be something called synarthrosis or synarthrodial, which are going to be completely immovable joints. These joints will not move. They are immobile. Anytime you see syn, S-Y-N, that means without. So this is saying without movement. Amphiarthrosis, this is going to be semi-movable joints. So these joints are going to be a little bit movable. They're not going to be completely no movement, but they're not going to be full on, full range of movement. They have a little bit of movement to them. And then diarthrosis or diarthrodial joints, these are going to be freely movable joints. Think of our shoulders and our hips. We don't have any restrictions. We can move in 360 range of motion. So starting off with our first classification, the type of materials that are made of our fibrous joints. These lie between bones that closely connect to one another. They have a thin layer of this fibrous connective tissue that joins them together. And it's going to have a lot of collagenous fibers, which is what you see in this left side picture where it has all these little stringies. You can see it has that collagen fiber, which is that very thick fiber, and then it has some of that elastin fiber, which is the elastic part of our bones. So again, these fibrous joints occur between bones that are going to be in very close contact with each other. An example of that are going to be sutures of your skull. If you press on your skull, it doesn't move. At least I hope not. If it does, please go see a doctor. That's not normal. But those sutures are fibrous materials that are holding these different regions of your bone together. Your skull is not just one massive hunk of bone. It's a bunch of smaller cranial bones fused together by these sutures, by these fibrous connective tissue. Our teeth are also fibrous joints. They help keep our teeth rooted into our jawline. Our bones, our teeth are considered bones. So we have our tooth, which is a bone, and our jaw, which is a bone. So those are two bones coming together, which are held together by something called a gomphosis. This is just the particular name for that type of joint. And our teeth don't move unless they're loose. That's a totally different thing. But as an adult, when you have your adult set of teeth, they shouldn't be moving. So continuing on, again, there's little or no movement occurring at these joints. Like I said, those are going to be those sutures or even that distal end of your tibia and fibula, which is going to be the lower part of your leg below that knee. There's going to be fibrous tissue that connects those bones together, and that keeps those bones from kind of sliding around. It keeps them working together in tandem. We also have cartilaginous joints. So this is the second type of classification we can use for what joints are made up of. So cartilaginous joints, this is going to occur where hyaline cartilage, aka the articular surfaces of our bones, meet, and our fibrocartilage, which is going to be like a shock absorber. These are going to connect the bones. For example, our kneecap, we have our femur that meets up with our tibia, and we have articular cartilage on both sides of our femur and our tibia. In between our femur and our tibia, we're going to have those menisci, which are going to be those fibrocartilage pieces that act as an extra shock absorber. Cartilaginous joints can be either synarthrodial, aka immovable, or amphiarthrodial, slightly movable. An example of this is going to be our pubic bone, which is what you see right here, that line you see that says pubic symphysis. That is going to be fibrocartilage. This is going to be a slightly movable or amphiarthrodial joint because, for example, and this is really only for females, when females give birth, their pelvic bones are going to need to stretch a little bit to make room for the baby's head and their shoulders coming through the birthing canal. So for that to happen, our pubic symphysis allows for that movement and that slight separation of our pelvic bones. This is an example of articular cartilage. This is your femoral head. So that part of your femur that goes into your hip socket. And this is what it looks like. So it's smooth, it's lubricated and glossy, which is why we're able to have a nice gliding motion when we move our hips. This is just a ligament that's showing it's helping attach that femoral head to our acetabulum. So that is what that looks like, just so you have a visual of what articular cartilage looks like. It is supposed to look kind of slimy and smooth because we want our femoral head inside of our hip socket to be able to move freely and easily. Our cartilaginous joint can also be the symphysis in between vertebrae. So our vertebrae do have a cartilaginous joint right here, and that's going to help with some shock absorption, right? When we're walking, our spine is constantly kind of compressing itself just from gravity and weight. And that's going to have our vertebrae kind of compress, and we need those intervertebral discs, which are fibrocartilage, to help with that shock absorption. Within our intervertebral discs, we're going to have different components. It's going to be composed of fibrocartilage, which is going to be called that annulus fibrosus, which is that outermost light blue ring that you see in that superior image. And then we also have the gelatinous core, which is called the nucleus pulposus. When you herniate your disc in your back, you're herniating this intervertebral disc. And what happens there is that nucleus pulposus, which is jelly-like, is going to protrude and push out from that annulus fibrosus. And that generally results in a nerve being pinched, which is extremely painful. So again, those intervertebral discs are going to absorb shock, and they're going to help equalize pressure as your body's moving. Our body's constantly trying to adapt to whatever movement or environment that we're in. So these synovial joints, these are going to be the most common joints in our body, in our skeletal system. They almost always, usually allow free movement. Majority are diarthrotic, which means fully movable. These joints are going to be structurally more complex compared to the fibrous or the cartilaginous joint. So we're going to be spending a lot more time observing these synovial joints just because they are more complex in nature. And you can see that they are found in your foot, your elbow, your wrist, your hands, your hips. They are all over your body. The three main characteristics of your synovial joints are going to be articular cartilage. You're going to have that smooth, glossy covering on the ends of any bones that are going to be in contact with each other. You're going to have a joint capsule, which is going to be this kind of orange color that you see on the screen. It's going to enclose that gap or that space in between where those two bones meet. And you're also going to have a synovial membrane, which is this purple color that you kind of see filling out that cavity in between those two bones within that joint capsule. So all synovial joints will have these three characteristics: your articular cartilage, a joint capsule, and a synovial membrane. So now we're just going to go into the general structure of these synovial joints. I highly recommend you draw something like what you see on the right-hand side that's labeled. I highly recommend you draw that out and just get familiar with how synovial joints look. But starting off, this subchondral plate, which is going to be at the most proximal end of the bone, at the epiphysis, this is going to be right beneath that articular cartilage. So this light blue that you see in this animation, that's going to be your articular cartilage. Right below that, in that bracket, that is going to be something called your subchondral plate. This is a somewhat elastic bone. It has a little bit of give to it and it will absorb a lot of that shock as we're walking or as we're running. For example, when we were talking about our lower body synovial joints. Our joint capsule, this is going to hold the bones together and create that actual kind of capsule looking structure. So what you see here in this box that says components of synovial joints, that whole kind of light blue or white that you see, that's going to be the joint capsule. It's going to have two distinct layers. That outer layer, which is going to be dense connective tissue. This is what we're going to call the ligament. The ligament is the outer layer of that joint capsule. Remember, ligaments are attaching bone to bone. Tendons attach muscle to bone. So when we're talking about a joint, we're talking about bone to bone, which is going to be tendons. As well, in that joint capsule, we're also going to have an inner layer. This is going to be a vascular lining of loose connective tissue. So it's not going to be as dense, as fibrous as our outer layer, our ligament. It's going to be a lot thinner. It's going to have a blood supply. And that's going to be something called our synovial membrane. We do need a blood supply into our joint capsule because we need those nutrients to keep our joint healthy, and that comes in through those blood vessels. Our joint capsule, while it does have some tensile strength, it is flexible, which helps permit movement. We need to have movement when we're walking, right? We don't need our knee joint to be super stiff. That's not its purpose. And the joint capsule also helps keep that joint strong enough to prevent those articular surfaces from being torn apart. All right, so those ligaments are going to be bundles of very strong collagenous fiber. Remember, collagen is going to be very tough with a little bit of give. These ligaments are going to reinforce that joint capsule, so give it a little extra backing, a little extra strength. Ligaments in particular are meant to help prevent excessive movement at your joint. So we need a little bit of movement, but we don't want too much movement because that's how we get injuries. That's how we hyperextend our knee. That's how we get MCL or LCL or other ligament tears in our knee, for example, is when we have excessive movement on a joint, moving it past what it's capable of. Ligaments are relatively inelastic. They act more as like a structural, keeping it sturdy at the joint, and it's helping to tighten the joint when it is stressed. So it's really just there to support that joint during movement so that we don't get any tears or injuries. Our synovial membrane is going to be that internal part you see here. It's going to be this light kind of pink lining or color you see in that animation. It's going to cover all surfaces within the joint cavity except our articular cartilage. So that's why you see that blue here. That's articular cartilage. Our synovial membrane doesn't cover that. The articular cartilage is already a covering that we have. So that synovial membrane will be found more on the medial and lateral sides of that joint capsule. The synovial membrane's role is to secrete something called synovial fluid. This synovial fluid is going to help moisten and lubricate those surfaces of our joint. If you remember the video I showed, I think it was in my kines class, but where we have that joint, our knee joint that doesn't have that lubrication anymore, it's just bone on bone, and our bone will catch on the other one, and it's extremely painful. So we don't want our synovial fluid to not be moistening that articular cartilage. that synovial fluid also supplies nutrients to the articular cartilage via blood vessels that are in your synovial membrane. Remember, it is vascularized within our joint capsule. So the synovial membrane helps keep things lubed up as well as nutrients supplied to it. So you can have your synovial fluid tested. They typically take it from your knee. It's kind of the easiest region to take it. And based off, based off of the color and the clarity, and then a couple of other metrics, they can determine what disease you may possibly have. So if you have yellow synovial fluid, you may have osteoarthritis. If you kind of have like a straw colored synovial fluid, you could have systemic lupus erythromitis. Oh, I don't know. My sister has it. I should know this, but systemic lupus. If it's yellow or milky, you could have something called gout, which is a type of inflammatory infection. Or if it's yellow to green, you could have rheumatoid arthritis. My brain, my thinky parts are not there right now, so bear with me. But I think that's kind of cool. You literally just take fluid from like your knee, and there's so many metrics you can do to kind of have an indicator of what's going on internally in your body. So continuing on with the general structure of our synovial joint, we have menisci within our synovial joint. Specifically, we're looking at an image of our knee joint. So we have that femur, which is that your thigh. And then we have your tibia and fibula, which is that lower part of your leg underneath your kneecap. So these menisci are going to be discs of fibrocartilage, just like in our spine, our intervertebral discs. These are going to be partially or completely divide those synovial joints into two compartments. The main role of these menisci are going to be shock absorbing, and they're going to sit on the articulating surfaces of those bones. So our menisci sit on the very top of our tibia, and our femur will articulate with the top of our tibia when we are doing any type of leg flexion and extension. These menisci will project up into that synovial cavity. And like I said, it serves as a cushion for those two articulating or interacting bones. These menisci also kind of help distribute your body weight, so that it's not just one region of your bone taking on all the weight and the stressors of that weight on your bones. We also have something called bursa. You may be semi-familiar with this if you've ever been diagnosed with something called bursitis, but your bursa are going to be fluid-filled sacs that are going to be located in certain synovial membranes. Not all of our synovial membranes have them, so only a select few do, like our shoulder joint, which is what you see in that left hand image, and our knee joint, which is what you see in that right hand image. These are usually located between the skin and bony parts of bones. So that is where they lie, or like if this is your skin and this is your bone, your bursa are going to be right in between those two things. Their role is also to act as a cushion as well as an aid for the movement of your tendons to glide over those bony parts, because we don't want our tendons getting caught on a bony part of our bone, because then that's going to inhibit range of motion as well as cause discomfort. And that does happen if our bursa gets worn down, then it's not able to do its job. So this, I would, like I said, sketch this down, sketch it out, and label the different components that we're going to go over, I believe in the next few slides. But this is going to be very helpful for you, not only labeling the location of these things, but also writing out the functions. Because remember, with the lecture course, those exams and assessments are going to be more heavily on concepts and functions, whereas lab is going to be very strictly identification. So doing this, you're really killing two birds with one stone, just saying. So starting off with our labeling, hopefully you have gotten out a piece of paper or something to do some labeling. We're going to start with that articular cartilage. Remember that articular cartilage is going to help act as a cushion and allow for fluid and gliding movement with our bones, because we don't want our bone-on-bone action. That's how we get arthritis and bone spurs. It's going to decrease that friction, and it's going to aid as a shock absorber. Next up, we have that synovial joint cavity, which is that yellow that you see there. This is what's going to contain our synovial fluid, which is going to give that joint capsule some viscosity, which just means some fluidity. Remember, our synovial fluid helps lubricate our joint capsule. Our synovial membrane, which is what you see in red, this is going to be the innermost lining of our joint capsule. This will also secrete that synovial fluid. Moving on to our articular capsule or joint capsule. And then we have the periosteum, which is going to be that outermost membranous layer of our bone. Remember, the periosteum is the outermost, the endosteum is the innermost layer of our bone. So, some joint injuries. This is some exciting stuff. Honestly, I would love to save this for in-person lecture. So I'm going to stop here. Again, make sure you have answered all of the questions. If I've done everything right and technology works with me, if the questions are embedded in here, if you've gotten to this point, that means you've answered all the questions. But again, please make sure you do that post-lecture response and take the time to draw out that joint and label that. I promise it'll be a valuable a valuable reviewing tool. Y'all aren't doing research. But yeah, go ahead and reach out to me if you have any questions. I hope you have a great weekend, and I will see you guys next week. This is always the awkward ending because I have to hit stop recording. Okay, bye-bye now.